Joey Sweet.
I should turn my microphone on. I'm going to do that again. We're calling this meeting to order, the Anchorage Assembly Health Policy Committee. So Joey Sweet is here in the room. I am member Voland. I'm here in the room. And then we have several members on the phone. If you'd like to introduce yourselves, go ahead.
Christopher Constant.
Meg Zolotel.
Felix Rivera. Solt.
I think that was Felix Rivera and Randy Solt. And then I think we have Austin there too.
Yeah, I'm here too. Good morning, and I'll be there in a few minutes.
Fantastic. Okay, so we're going to move on in our agenda. First, we have an item of unfinished business on mobile crisis team job classification. I don't know if we have anybody from the administration here to speak on that. We have our acting municipal attorney. Yep, mobile crisis team job classification. That was a topic at our last health policy committee. Are you prepared to speak on that? Have we made any progress on job classification to get our mobile crisis team operating at 24/7? Okay, so I don't think we have a member of the administration who is prepared to speak on that item at this time, so we will move on to new business, and we will start with our standing report from our Anchorage Health Department Acting Director. Go ahead, Ms. Rash.
Thank you, and good morning, everyone.
Mr. Chair.
Oh, go ahead. Yep, Member Quinn Davidson.
Sorry about that. I was just going to note that moving to 24/7 is something that's been funded for quite a while. I think since July 1 of last year, we've been talking to the administration for months and months about it. Ms. Alto and I met with Ms. Demboski and Ms. Christensen, who ostensibly solved the problem, and now the problem is back. So it seems like a problem of either will or skill, I'm not sure, but it's getting extremely frustrating, and those with behavioral health and mental health issues are suffering as a result in our community, not to mention residents who APD cannot respond to as quickly because they're dealing with it. So it's just extremely frustrating once again to not have an update from the administration. Thank you.
I think I have a couple members in the queue. Member Zolotel, did you want to be in the queue or taken out?
Actually, thank you. I think we've heard really clearly from IAFF that they're ready to come to the table to talk about an EMT only classification. I really encourage the administration to start that process. I saw on the upcoming agenda an item that will be a pass-through grant for a mobile intervention team for APD. I will tell you, I'm very reluctant to move the APD component forward unless we get concurrent movement on the mobile crisis team. We were really clear when we passed the budget that the mobile intervention team was a one-year pilot and then compare the data between the two programs. But that means both programs need to be moving forward at the same time in the same capacity. So I think we'll have further discussion with that item on Tuesday night, but really need the administration to come to the table so that we can move these classifications forward because we've provided the funding. And I think there was a recent item that showed that the mobile crisis team funds from last year were underspent by like nearly $2 million. And this is just not acceptable. Thank you.
Thank you, Member Zolotel. I'll say that I agree. I think the goal is an integrated model. I want to point out that Member LaFrance joined us at 9:18 a.m. And then next I'm going to go to Member Constant.
Thank you. I'm just going to put a sharper edge. When the Assembly passed the budget, we added by amendment full funding of that mobile crisis team years ago. And we have witnessed the administration refuse to implement it. And they've come up with every excuse why they refuse to implement it. It's like a child having a tantrum, not getting their way. There's no other way to look at this. And I share the position that there won't be additional funding for other aspects of this response with APD or others until such a time as the administration gets off their tail and does the work that the budget is set out to do. Because we're years in now, and this failure is just one more in a long chain of failures by this administration.
Thank you, Member Constant. Member Cross just joined us at about 9:20 a.m. here in the room. I wonder, do I have anybody here in the room from IAFF who wants to speak on this topic? I thought I had seen maybe. No? Okay. Any other comments on this item, Mobile Crisis Team Job Classification? Alrighty, I don't see anybody else in the queue. So moving on to Ms. Rash's standing report from the Anchorage Health Department. Go ahead.
Thank you so much. So WIC is working on Northwest strategies to place 2 radio ads. The Aging and Disability Resource Center has placed an advertisement in the upcoming senior living section of the Anchorage Daily News and placed a full page advertisement in the yearly publication Older Persons Action Group Directory. Our Get Moving Anchorage campaign continued in January with a Penny Pincher Challenge, which challenged everyone to take one step to improve their financial well-being. January saw 18 participants in this campaign, and then challenges can always be submitted online through our portal. The February challenge will focus on staying relaxed and well-rested in the Yogi Challenge. Our Anchorage Opioid Task Force project is paused until pending receipt of the opioid settlement funding needed to fund the task force. So we are working with OMB and Finance to move the funds to AHD for utilization based on Exhibit E of the Settling State Abatements Account Fund. This exhibit focuses on core strategies of upstream, primary prevention, treatment, harm reduction, and recovery. Access to Care for Anchorage 65 and Older Task Force will convene on March 2nd, which is tomorrow at AHD, to discuss those affected by the recent closure of Alaska Regional Senior Health Clinic. We have received a lot of interest and participation, and Dr. Sabat can speak more to that on this topic. So currently with our vacancy rates, and I know it is a topic on our agenda here today, but I'll kind of just briefly touch on it now. As of January 2023, our separations are outpacing our new hires at this point. And that began in January of 2021. We currently have 144 positions within the Anchorage Health Department, and we are currently at a vacancy rate of a little bit around 34%. Anchorage Safety Center and Patrol. Overall, 331 individuals utilize services more than once, therefore creating 525 intakes or occurrences due to multiple visits. They transported 413 individuals and responded to 1,074 calls. In Environmental Health Services, the program addressed 72 complaints in January. They performed 107 inspections and made 1,239 customer service contacts. They renewed 21 liquor and marijuana retail licenses, responded to 6 foodborne illness reports, completed 7 and worked on 21 plan reviews, issued 66 permits, and administered 14 food worker cards. All of these numbers are in alignment with previous year, with inspections, permits, and complaints being received. Our Women, Infants, and Children program, or what we like to call as WIC, had a participant total of 3,911. A family service aide started in January, and we currently have 2 open registered dietitian positions and 1.6 open family service aide positions. WIC is in discussion with local medical providers to establish an efficient referral system and partnership similar to Anchorage Neighborhood Health Center. The partnership with ANHC is moving forward to track referrals being sent from them and review for decision-making purposes. WIC attended the Polynesian Association of Alaska's 8th Annual Diversity Community Health Fair on January 21st and reached 75 contacts. We hope to open the Eagle River Satellite Clinic in the near future. Additionally, we are working towards establishing another office at the Muldoon Center and moving our clinic on J-Bear to the Elmendorf Hospital. The team is providing informative classes to pregnant women at J-Bear on a regular basis. The WIC clinic team completed anthropometric and hemoglobin training as a team. Their internal enrollment and participation work group is meeting to strategize on how to improve results, and staff are working on developing an efficient data report to track work and outcomes. The program reached 1,749 people on their Facebook page with 23 posts in January. Our WIC breastfeeding peer counselor program, we currently have 2 counselors that are on staff providing breastfeeding support to 114 women currently enrolled. 276 total contacts were made in January to the 114 enrollees. 10 Facebook posts and 9 Instagram posts were made in the month of January. Facebook page reached 447 people in the month of January with 2 new followers. On Instagram, we reached 189 people for the month of January, and they hosted their first TLC, which is the Lactation Club, in-person event in January where families receive breastfeeding peer counseling while completing winter crafts with their children. SNAP-Ed. So our SNAP-Ed educators meeting with local grocery vendors to provide SNAP education, observe WIC product displays for data collection, strategic planning purposes, and partnering with WIC to provide nutrition education in the community. We're reestablishing relationships with Covenant House and Aquila to continue providing services. More partnerships expect to develop over the next year with community partners. We started conversations with the Alaska Farmers Market Association Food Access Coordinator to collaborate in springtime trainings for farmers market staff on accepting SNAP and nutrition at farmers markets. Our SNAP-Ed attended also the Polynesian Association of Alaska's 8th Annual Diversity Community Health Fair, and they reached over 200 individuals at this health fair. In our community health nursing program, we continue to provide immunization records and COVID card replacements upon request within 2 to 3 business days. They tracked 5 cases of salmonella, 1 case of bacterial invasive disease, 3 cases of campylobacteriosis, and 1 case of giardia. Sorry about that. Immunizations. So we performed 77 routine vaccinations, which were provided to our community members. And there's a whole list out of which ones were provided. Tuberculosis control, we treated and case managed 14 clients with active TB. We completed 82 blood tests and 13 skin tests, excuse me. In our sexual health clinic, our STI Express service is a walk-in screening focused specifically on STI screenings with low barrier or no cost to client that can reduce visit times, decrease time to treatment, and use provider time more efficiently. 14 clients were seen in this STI self-referral walk-in clinic, 33 during outreach. We had 0 positive tests for chlamydia, gonorrhea, HIV, hepatitis C, and syphilis. 58 naloxone opioid kits were given out by AHD in January, 1 within our sexual health clinic, 3 to our clinic front desk staff, so those sitting at the front desk handed those out. And 54 kits were given at the LUSAC Library's Polynesian Association of Alaska's 8th Annual Diversity Community Health Fair. 7 rapid HIV tests were performed. 2,440 condoms were distributed at various locations citywide. 65 youth received preventative sexual health education in the month of January, and 4 presentations to 4 cohorts of youth at McLaughlin Youth Center and OCS Foster Youth Independent Living Program, and the presentation was on birth control. Thank you.
Thank you, Ms. Rash. Any questions for Ms. Rash? Member Cross, go ahead.
Ms. Rash, thank you for being here this morning. I had a constituent, I believe he's a fire protection contractor, does range hood inspections, and he said he was a little concerned over some of what they had been viewing on kitchen hoods and kitchen inspections. And I wanted to speak to, as far as the health departments, as far as where we're at on food and restaurant inspections. I would, and I'm kind of curious on, what number of inspectors we had going into COVID, how many we lost, because I know we lost on the other side of that. Are we at the same amount of inspectors, even though we have fewer restaurants? And what are we doing to either get caught up, or maybe you could just speak to that metric in there? And if that's maybe he's just seeing something unique, or if there's actually a challenge here that we're trying to address. Thank you.
Thank you so much for that question. So I cannot speak to previous COVID years with inspections or inspectors. However, I can get that information for you, kind of do a deep dive and see where we're currently at historically and then moving forward. From what I understand now, within our environmental health, we have only one vacancy currently. We've had 2 promotions, so one person was still in training and learning the ropes. But from what I understand, they're addressing all the calls that are coming in and within the community.
Okay, but so I appreciate that. So what I'm just looking for is, what is our normal track record of inspections being performed a year? How many people are there, and where are we at now? And are we doing less with more people? Are we doing more with less people? What are those actual numbers, so I can get an idea of where we're at on track, so that when individuals come to me with concerns, I can say, actually, here's the numbers. So
Okay.
Thank you.
Okay, next I have Member Constant in the queue.
Thank you, Ms. Rash. So when we hear about 30% vacancy at the health department, that's really a heavy number to hear. The question is 2 parts. 1, what does that mean for your budget? And 2, what's happening for recruitment?
Thank you for that question. I can start to answer this now, or would you like me to wait until we get to that agenda item?
Thank you. We do have that as a sort of a separate agenda item
Okay,
on
that's
Anchorage Health
fine.
Department
You can wait.
vacancies. And hopefully we can drill down on some of that stuff. Any other questions for Ms. Rash? Mr. Sweet, go ahead.
Thank you for the quick reply to my email the other day. The closure of the senior health clinic at Alaska Regional is a real priority for me. I'm glad to know that the task force is being brought together to address it. I received an email about it yesterday, but it didn't seem to say when or where the meeting is. So if you would let me know that, I will try to prioritize myself or my assembly aide being able to attend. So what time and where is it?
Thank you for that question. I have Dr. Savitt here, if that's okay, if you can speak to that.
Sure.
Thank you.
Mr. Seven or Dr. Seven? You want to make sure that microphone is on, really push it hard and that green light comes on. Perfect.
Thank you. Good morning, everyone. Thank you for the opportunity to address this very important issue. I'd like to start out by saying that I always hoped I would live long enough to get old. I just didn't expect it to happen this fast. And I suspect a number of people in our senior community have the same thought on that. Medicare insurance is something that is very important to a lot of folks. Medicare, being able to see a provider with that Medicare insurance is very important and is increasingly more difficult across the entire country, but especially so in Anchorage. With the closure yesterday rather, of the Alaska Regional Senior Clinic, that leaves, as far as I know, from what I've been told, approximately 4,000 senior Medicare insured without a provider. We have 2 clinics, 2 facilities that are currently accepting Medicare, Anchorage Neighborhood Health and Providence Family Center. But with 4,000 additional folks to take care of, they will quickly become overwhelmed. Seniors have more chronic health conditions. They have age-related conditions, obviously. They require more care. Now we've got an awful lot of folks that are not going to be able to receive that care and will most likely feel the need to go to an urgent care center, urgent care, or to an emergency room, both of which provide good care, but were never meant to take the place of primary care providers, especially for a senior population. To that end, I have discussed with folks in the health department, probably since I found out this was going to happen back in December, to try to come up with ideas as to how we can address this issue. I have spoken to the mayor already. I have his full support. And with that in mind, we've formed a work group. It's being called a task force, of course, to address this issue. Our first meeting, the first of which I suspect will be many meetings, is due to take place tomorrow morning at the health department at 10 o'clock in our main conference room. We will be seeing folks person to person directly, and it will also be over Teams so that folks who can't physically get there will have the opportunity to participate. What we are looking for, essentially, short-term solutions to address the immediate needs of folks, which would include patient visits, refills on prescriptions, and a whole host of things. I don't want to go into a whole list of those right now, but short-term solutions would also include forming strategies to attract Medicare providers. So recruitment, retention of those providers, and there's a number of obstacles there. Medicare reimbursement is very low. The process to obtain that reimbursement is difficult, a lot of hoops to jump through. We also need to address long-term solutions. Medicare, as you know, is a federal program. So we need to have our state senators, federal senators, Ms. Murkowski and Mr. Sullivan, our Representative Peltola, and any others at the federal level who can try to intervene. It's going to be a very tough job to do that since this involves changing law. But it is, as I said, a long-term solution. So the meeting tomorrow, let me address that since that was one of Mr. Sweet's questions. And in fact, I'm going to address all of those questions in short order. The meeting is to address these short-term and long-term solutions. We have invited community partners to participate in this. They are actually what we would consider our subject matter experts. This would involve folks from the hospitals, the clinics that are now seeing Medicare-insured patients, and other groups such as the RPEA, I think it is, and the Anchorage Health Department Senior Citizens Advisory Commission. I've been to both groups to speak to them, to advise them of the problem, which they actually already know about, of course, and to invite them to participate. They're willing to participate and help in any way they can, which is really very gratifying. We are doing feasibility studies within the health department to see what we can do to accommodate some of these folks as well. So let me just backtrack to make sure that I answer the questions that Mr. Sweet had. How often will the task force be meeting? We hope to meet every 2 weeks, sooner if needed. We have a long list of folks that have been invited, and I don't have that with me, unfortunately, but that's easily obtained. There's an offer from Mr. Sweet to provide any support, and I really appreciate that offer, and I'm hoping that you and any other members of the assembly that have the time to participate will be willing to do that. This is a problem that will affect many folks in our community, and anyone who is willing and able to offer help, please participate with us. This is going to be an issue for years, I would think. As each year goes by, more and more people will be old enough to require Medicare insurance. There's one last question. Will we be able to have monthly updates in the health report? Yes, absolutely, because I think this is a vital mission now of the health department. And I would be happy to answer any questions anyone has.
Thank you, Dr. Savitt. I would extend an invitation for you to attend our April meeting of the Health Policy Committee as well and present on the discussion. You are somebody from the task force, and any recommendations that you have for how the assembly can be supportive. Any questions for Dr. Savitt? Go ahead, member.
Invitation.
Yep, go ahead, member LaFrance.
Thank you, Mr. Chair. Thank you, Doctor, for being here. Follow-up question. Did you say twice monthly on the task force?
We're hoping to meet approximately every 2 weeks. It's difficult to obligate folks to meetings of that frequency, but that is our hope, that we will have more of a core working group as time goes by, and we'll try to accommodate their schedules as best as possible. But this is a very important subject that can't wait.
Agree, thanks. And would you share that invitation with the clerk's office so that we could get it on the calendar and notice it if need be? Because if there are more than 2 members, really, 3 is the number, but we want to make sure it's noticed so all the members could participate if they want to. Thanks.
Be happy to. Thank you.
Okay, any other questions for Dr. Savitt? I don't see any in the queue, so thank you for being here and for your report.
Thank you very much.
Yep. I think at this point we will move on in the interest of time to our next item of business on the agenda. And we have some folks here to present on the Providence Crisis Stabilization Program. So if you could come up to the table here, we are very excited to hear your presentation. Okay, great. Thank you for being here. If you could introduce yourselves, and you want to make sure you push that big button real hard and that green light turns on so we can all hear you.
There we go. Hi, good morning, everybody. Katie Baldwin Johnson. I'm Chief Operating Officer at the Alaska Mental Health Trust Authority.
Good morning, I'm Randy Schaefer. I am the Director of Community Behavioral Health for Providence.
Fantastic. Take it away.
Great. Katie, you want to start us off?
Sure. Thank you for scheduling some time for us this morning. I'm just going to kick us off just with some kind of higher level context for the work that Providence is doing. And I think the majority of the time we'll want to focus on hearing from Randy updates on the good work that Providence is doing around crisis stabilization. So the Trust has been actively working on a statewide initiative in partnership with the Department of Health, Department of Family and Community Services, Providence, and other partners, including the city, the fire department, APD, so many partners here in Anchorage, to think about how to redesign how we respond to people in behavioral health or psychiatric crisis. We know that the way it exists currently, we're not unique in Alaska, but police tends to be the primary responder to community folks in the community in crisis, and hospital ERs and jails are often the disposition for those folks. So using the Crisis Now framework, and we won't spend a lot of time going into that, it's just an effective way to design community response to individuals that's very intentional, well thought out and planned and coordinated. So on a statewide initiative, we've been thinking about this in various communities, working with Anchorage, working with Fairbanks, Mat-Su. We have other communities that are coming online, Juneau, Ketchikan, Kotzebue. It's Copper River area. It's really exciting that communities are stepping forward and thinking about, well, if we apply sort of this concept of somebody to talk to, so somebody to call if you're in crisis. If somebody needs more, there's a local response where people can dispatch to the community and respond to people in community. And if they need higher levels of care, there's places to go, like the Providence Crisis Stabilization Center, rather than emergency rooms or sitting in the back of a police car or whatever tends to happen with that currently. So in order for us to have a robust system in Anchorage, we really have to work at this at a state level. We have to address the policy areas that will allow us to provide new types of services. This is really a new paradigm in terms of thinking about how we respond to people in crisis. So success at a local level depends on our work at a state level. And certainly in Anchorage, we have all the partners that are actively working on this and have been since, I would say, pre-2018. Providence and South Central Foundation really stepped up and started thinking about how can they partner to think about working on these issues. And it was just kind of a perfect partnership. The trust dove head in, obviously, because of the impact to beneficiaries of the Mental Health Trust. This work makes sense for us to support that, and that's why we are here today. I will say there's been lots of activity. Providence and South Central Foundation and others have spent some time looking at how these models are working in other places, not only in Arizona, but other types of stabilization programs. The trust has supported Providence with initial planning funding. They've worked really hard at this over the last year to be very thoughtful and planful, thinking about these services so that they are safe and effective, and they're developed in collaboration and in coordination with others in the community. Great programs like the Fire Department Mobile Crisis Team, that's a key part of this, our partnership with APD, and then also the connectivity with the statewide call center, the statewide crisis call center. So I also want to mention, if you want to just go ahead and move to these are the stars on the map that represent some of the work that's happening statewide, and specifically in Anchorage. We have support with contract management that's working with Providence and the local crisis collaborative, which is a partnership of key folks that are really being a part of solutions here locally. The fire department, the police department, Providence, behavioral health providers. I could go on and on. There's lots at the table that are thinking about this at a local level. On a policy level, some key legislation was passed last year. House Bill 172, the title of that bill was, I think it was Mental Health Facilities and Meds. It's kind of an interesting title. But what that does, it creates in statute the ability to have crisis stabilization programs like the one that Providence is currently planning. And you'll hear more about that shortly. The trust has continued to be supportive of this at a statewide level, and certainly of Providence and others like South Central Foundation that are focused on this. Recently, the trustees approved a grant for a second phase with Providence for a startup, ramp up, and launch of this project that you're going to hear about shortly. So I'm going to pause there and hand it over to Randy, and I'm here available for questions.
Great, thank you. Who's reading the slides? Is that you? Okay, you can move to the next slide, and I'll try to keep us on a time. Do we have a specific time? I want to try to.
I think we're doing good.
We're doing well? Okay, thank you. Thank you so much for the opportunity to be here today and to talk about the work that Providence is doing to support the Crisis Now model being implemented in our state, and just acknowledging the trust and all the work that you've done to really create a shared vision and a shared language for how it is that we talk about crisis and crisis services. I think it's really refreshing anywhere you go that people really understand what a crisis continuum is and what we're talking about when we're talking about these next services that Providence is going to be adding to the continuum. I'm sure many of you are very familiar with this graphic that looks at all of the various services, and the Assembly has been very supportive of enhancing dispatch and creating the mobile response teams, both in AFD and new work and expanding the APD services, enhancements to the crisis call line, all of those pieces. Those have been really important pieces of launching the crisis continuum in Anchorage. We have worked closely for a number of years with the AFD mobile crisis team, both in helping inform them as they were developing their team, as well as ongoing collaboration. Every encounter that they have is informing us of the services that we need to be building to stand up the next level of services, which if you want to move to the next slide, you can see in the continuum the highlighted areas that Providence is designing currently is a 23-hour crisis stabilization center, which will include 3 distinct services. The first one being more community facing on the bottom, and you can see that's a behavioral health urgent care clinic. And that's a Monday through Friday, about 10 hours a day. The clinic will be open, serving individuals in crisis, much like you would walk into an urgent care clinic for a sprained ankle. You can walk into this urgent care clinic for in need of behavioral health care, or we're also providing substance use services in that setting as well. In the design, we also decided at this level of care that we are going to expand services to also provide care for adolescents. So our urgent care clinic will serve our community members age 12 and up. The other 2 services are a 23-hour crisis stabilization center, which means individuals can come and be in that program for up to 23 hours. It's an opportunity to receive assessment, stabilization, and intervention. And some of those community members will be discharged within that 23-hour time and be able to return back to the community. And then we also have our 24-hour crisis residential program, which provides short-term crisis residential stabilization, about up to a week stay in that service. And I can drill down a little bit more as we move along, but really wanted to talk about the design approach that we're taking to these services, because in the crisis continuum and even in the Crisis Now model, there are crisis stabilization services that serve a gamut of acuity levels. And we, through our partnerships, through our research, we have determined that Anchorage really needs a no wrong door crisis stabilization center. And that is because it's, of course, we all hear story after story of people falling through the gaps, falling through the cracks and not getting the care that they deserve. And we want to be able to serve individuals in crisis with the most effective, timely, evidence-based, trauma-informed practice as possible. But our other customer, if you will, the other individuals that we are going to be serving with this crisis stabilization center are our first responders. Our first responders who are out in the field, police, fire, the mobile crisis team, and API also. That level of care is one of our customers in this, and our healthcare providers who are ill-equipped and ill-prepared to serve the intense behavioral health needs that are showing up in our emergency departments and in our primary care clinics as well. We get calls regularly from primary care physicians asking for support and help for their patients that are coming into their offices. So we really feel strongly that we need to stand up the highest level of crisis stabilization center so that we can accept both voluntary and involuntary clients. And that will allow us to be a true no wrong door center. So with that, of course, there's increased complications or increased barriers, I would say. We're not going to call them barriers anymore. We're going to say there's increased challenges for us to face. One of them, of course, being cost, because when you're standing up the highest level of care, it needs to be in a very unique environment where every single item that's in the environment is anti-ligature, that people are going to be able to be served in an environment that is going to be able to protect them when there's episodes of violence or episodes of suicidal ideation or attempts in an environment. So we do know that there are some challenges associated with inflation and just overall the challenges that Providence and all other really healthcare, organizations are facing currently with trying to recover from the pandemic. There are tremendous financial burdens right now. It's a to put it lightly, it's not the best time to be standing up a new, very expensive service because there's a lot of pressure and a lot of stress. But with that being said, Providence is very much committed to this. We know that, like Katie mentioned, we've been in this discussion for a number of years pre-pandemic, and we know this is the right service to be providing, and we're fully committed to that. And we've had a tremendous amount of support from, the Assembly and the support that you've provided, our state partners, as well as other private funders as well. And I can share a little bit more about that. But wanted to make sure that everyone understands that we are standing at the highest level of crisis stabilization service. We will be serving voluntary and involuntary clients. Let's see. You can move to the next slide, please. Just to drill down just a little bit more, actually, and I think this slide really speaks for itself, to show you a little bit more of the description of the services and our estimated treatment episodes. Combined, we're looking at an estimated 7,700 patient days per year of services. Let's see, next slide. This is a little bit of just a graphic to show the timeline. Where we are right now with development, we are at 35% design with our build, and that's giving us a lot more clarity around our funding gap. And so we have identified a funding gap for capital associated with building costs and standing up the services. We are really in a place right now where we have just a strong imperative to secure that final funding so that we can move forward and develop the services on time. We're looking for standing up the urgent care clinic in December, the end of December of this year, so that we will have that service up and running and launching the 23 and 24-hour part of the programs in Q1 of 2024. I think just making sure that I pause for just a moment to acknowledge the challenges that we have associated with workforce. That's not new to anyone. We have a significant recruitment project going on right now to start to pull in the specialized talent that we're going to need to be able to provide these services. Looking forward into 25 and 26, we are anticipating that we will be able to be at full functioning. And sorry, just backing up a little bit, we will be opening at 50% for a while in order to get our staffing up to speed. So continued services and full functioning, which in crisis services is usually at 75 to 85% of capacity at any given time. And then over the course of the 25, 26, we're looking at this project being able to reach financial break even. This really is a community service program. This program will not be revenue producing in 25 or 26 or moving forward. Providence sees it as a community benefit. We are hopeful that we'll be able to break even, but for ongoing sustainability, it really is going to require the continued support that we've had in terms of launching from the trust and city and state, and really at the federal level in terms of reimbursement rates and those kinds of things. So it's going to take, we really can't stress enough how much the ongoing partnerships are going to be important for sustainability. Next slide. This is the exciting part. We're here. We have a plan. We have a map. We have a building. These services will be going into an existing Providence building, the Alaska Regional building, which is the old API, for those of you that have been around Anchorage for a while. So it is on our campus, which allows us close access to ancillary services. We will be using our Providence Alaska Medical Center food and nutrition support, laundry services, and so forth, as well as just access to things like laboratory services and so forth. So it's a great location. We've operated crisis stabilization services on the other side of that building for about 15 years, serving currently just adolescents, but we also used to serve some adults on the crisis recovery center side of things. So you can see the behavioral health urgent care is in one area with that back area where you see the large pink square area is also provides some programs and services for our substance use disorder clinic. And then we have some staff area. We have a wellness room for our staff. And there's also wellness rooms on each of the 23 and 24-hour unit for our clients. On the end of the 23-hour, you can see some small letters up there, but that is our first responder drop-off. We've partnered very closely with AFD and APD around the design of the drop-off because that is such a crucial part of the No Wrong Door. We want to make that space as easy and welcoming to our first responders as possible. Our goal is to have drop-offs occur within minutes. We also have created a first responder room at the very end of that where a quiet space where if a police officer or the mobile crisis team needs to step in to do some paperwork or have a snack, we can take care of them as well. So that's very exciting. We've got specialty services helping us to design an environment that's really conducive to this type of care, creating a trauma-informed, really calm, low stimuli, nurturing environment so that we can best serve individuals. You'll see there is the door in the picture is our current front door. There will be an additional front door that's built for community members to walk right in to the urgent care center. And then the sidewalk that goes around will also allow individuals to come to the crisis directly to the 23-hour as well. Individuals always start receiving services at the 23-hour side of the building, even if we recognize right away that they will need, maybe a couple days. They don't have to stay for the full 23-hour. On that side of the building, they can be moved pretty quickly to the crisis residential side. But everyone starts services there for those two programs. So people wouldn't be admitted from the community directly into the 24-hour care. That makes sense. All right, we can move to the next slide. This is, just a graphic that we developed in conversations with our mobile crisis team friends about what they were seeing in the field and what is it that we need to provide to continue to serve them. And a possible guest at the urgent care clinic, the team described, like a teenager who's experiencing anxiety and suicidal ideation, really not able to identify resources. They might have a plan for suicide. Currently, the way that this adolescent would be served if the mobile crisis team was unable to support them in place, which is of course always what we hope can happen. But really the only choice at this point in time is to go to the emergency room, and emergency rooms are just really ill-equipped to provide the services that this adolescent would need. They may or may not have access to someone with behavioral health expertise in the emergency room during an emergency room visit. Emergency rooms are often very loud and overwhelming and can in and of themselves be a traumatic experience. They can be side by side with individuals in medical distress or psychiatric distress. If they were able to go to the urgent care clinic, they receive de-escalation, assessment, and intervention. That's the other thing, really in emergency departments, the interventions are provided assessment and triage. And so this is going to allow for treatment interventions to be provided to the individual as well as to the family. We've specifically designed some of our urgent care consultation rooms to be larger because we are serving an adolescent population, and as well as we want to be able to support family members who are coming in with their adult family members as well. So there's also opportunity for family intervention. We can provide, they can be seen by a nurse practitioner or a psychiatrist and receive prescription medication, and then comprehensive referrals into community with the opportunity to come back in between the time that they would be able to get into an outpatient appointment, because we know that there's significant wait times for individuals to receive care. And so if they're troubled and struggling before they get into regular care, this is a safety net for them. And in addition, we shared an example of a case where an individual was experiencing a first episode of psychosis, and really because they were not willing or able to be accepting of care at that time, and they were not voluntary status, it really impacted the ability for them to get care, because they have to really get sicker and be in a much higher level of distress before they're going to meet the involuntary status to be able to be served. And so what can happen with an individual like this example with the 50-year-old experiencing a first episode of psychosis is the mobile crisis team is going to be responding to them over and over again, or a police will be responding over and over again before they get to a point where they're able to possibly be seen in a hospital. And then oftentimes when their symptoms are so severe, they can't be stabilized in the emergency department. And so they need to seek care at API. And then wait times can be sometimes days, even weeks. Individuals are sitting in emergency departments because of how overwhelmed API is as well in our system. So with our new system, that same individual could come to the 23-hour stabilization unit. A specialized team is shown to be able to help individuals move from a non-voluntary status to a voluntary status in a much more timely manner. The specialized environment and support allows someone to get into a place where they're able to accept and on their own feel empowered to seek help. And so that's when, a significant benefit to this environment as well. We don't have to serve as many people involuntary because we can help them move to a voluntary status. And so they can be seen and assessed, and we will be able to, quickly identify that this individual is experiencing an episode of psychosis and be able to move them swiftly and in a nurturing manner over to the 24-hour program where they can stay there, 3 to 7 days and be able to get started on the medication that they need to address their medical and psychiatric needs.
That's awesome, Brandy. Hey, in the interest of time, I think I do want to open it up for questions from the members.
That sounds great.
Great. Any questions?
And we can just move to the next slide just to.
Member Cross, go ahead.
No, that's excellent. I'm curious, is it your intention, or have you already, are you working with to have a representative at the Catholic Social Services Navigation Center where they have individuals come in and they're kind of trying to navigate people to the appropriate services? I know that there's a big call for mental health support in these places. And then we're looking at potentially other locations around Anchorage to be providing these hubs where individuals come in, because until you can, you understand how it is when they come in, you don't know what the problem is, but having a selection of resources for that individual that's on site. So I know that you've got your own building, but is there communication with those navigation centers to make sure those people are expedited appropriately to receive proper services in a timely manner?
Yeah, absolutely. Absolutely. And I didn't say it earlier, but a key component of this crisis stabilization center is we will be using peer navigators as part of our treatment team, individuals with lived experience who will be on site at every level of care to help promote quality of care. We're going to be partnering with numerous community agencies. This, our center is not, the one size fits all. It's not going to serve all of the needs. It's going to be really important that we have a lot of relationships, like Catholic Social Service Navigation Center that you're talking about, for ongoing outpatient services. And yeah, please do.
And this is Katie. If I can just add that part of the community collaboration and planning around that crisis collaborative group, it includes partners like Catholic Social Services and others. There's also a connectors group, which is really about when people come through the front door, we need a back door. Like, we need places for folks to get reconnected back into system, into services. So connecting with the Navigator program there is going to be really key. I imagine this program will probably support many of their folks that they encounter there, and vice versa.
All right, Member LaFrance, go ahead.
Thank you, Mr. Chair, and thank you both for being here today. This is really exciting and fantastic news for our community. I have two questions, and they don't necessarily need to be addressed now because I know time is short, but I would like to have a better understanding of the role of the municipality. I know that you mentioned, the assembly support, financial support through ARPA funds, and then also the police department and the fire department. And we, did have a brief conversation at the beginning of this meeting regarding the challenges concerning the mobile crisis team, and the administration's difficulty with getting some of those aspects implemented. So again, not necessarily for now, but at some point. And then I peeked ahead because the presentation is posted online. I know you're going to be covering the financial aspects. And I do have questions, again, don't need to be addressed right now, just about the ongoing operations costs and what sources of revenue. I think later in the presentation, there's a $1.1 million subsidy of operations that is identified, if I read that correctly. So just would like to, understand more about the sustained funding, because this is something that just really sounds incredible and obviously is really needed statewide, not just in our community. So thank you so much for your work on this. Thank you, Mr. Chair.
Thank you. Yeah, I will echo that. Perhaps there would be an opportunity to have you all come back in April and present more specifically on that financial need component, and the local part, and then what you're going to be doing to get some state support, because I think that's one thing that we have our eye on is, there's the need in Anchorage is great. How can we get the state to step up and help us as well? Next in the queue, I'm going to go to Member Solt.
Thank you, Chair. So my question is just want to understand what you think like the mental health needs are for Anchorage, right? Just like a percentage of the capacity we're meeting. So if our current services are meeting 30% of the capacity or 20% or 100%, just kind of curious how far behind the curve we are. It seems like a lot of the homeless have mental health issues that we're just not addressing.
Yeah, I don't know that I can speak specifically about the numbers. I can definitely, gather some more data. What I will say is that, we are, I think, most all aware that, Alaska is at the highest rating. Oh,
Is your microphone on, Randy?
I think so.
Okay, yep.
Maybe
Maybe a little closer,
maybe a little
so
closer.
the other Randy can hear you.
Okay, sorry. We are at the high end of all of the ratings that we don't want to be high on in terms of child abuse and neglect and substance use disorders and domestic violence and suicide. And so overall, we're, underserving our adults and adolescents. And we have a court order around how to improve serving adults. And there's also a recent Department of Justice finding in adolescent behavioral health. So we're far underserving the needs of our state, and the ways that we are outdated and they're not adequate. So we're taking care of people in inadequate settings, and also at the same time the most expensive settings. So we are burdening our fire department, our police department, first responders, we're burdening them, as well as we're taking care of people in the emergency room. So I think the cost, not only the emotional toll that it's taking on not caring for our community members, as well as the financial burden, is significant. And I also, if I could just take a minute to share one of the, I think for me, the level of understanding that I have gained from this experience in going to Arizona and spending time with people that have been working in crisis work for quite some time is that we always knew this was going to improve the lives of people in crisis in our community. But what I really come to understand at a very deep level is we are going to be improving the lives of our community members in all walks of life. Because what we hear over and over again, healthcare workers are leaving the field in record numbers, and it's because of the moral distress that they feel by sitting in front of someone and they know the diagnosis, they know what they need, but they don't have the tools or resources or skills to provide that care. And the same that goes with our police officer, Lauren Anderson, who's the manager of our program of the Crisis Stabilization Center. She and I spent 2 days in Arizona working side by side with the RI team. And we made a point to talk to every police officer that brought individuals in. And when we told them that we were working on standing up services in Alaska, a stabilization center, over and over again, we heard the same thing, which was, your police are going to be so happy with this. This is the best thing ever. This has made me be able to stay in this work. This has made me want to continue to be a police officer. And talking about how distressing it was before, when they were sitting with people and they either had to leave them where they were because there was nowhere for them to go, or they had to go bring them to a hospital and sit for hours waiting for them to be received. Or, all of the options were awful. And so when I think about, we want police officers to stay in their jobs. We want firefighters to stay in their jobs. We want healthcare workers to stay in their jobs. And this is going to be a tool that's really going to help keep people well and keep people finding the joy that they have in their work and being able to stay resilient as we move forward, because we know our challenges are only going to become greater.
Thank you very much. Any other questions from members? I don't think I have anybody else in the queue. I'll just say this is exciting to see how some of our community partners are working so hard on standing up one leg of the tripod of the Crisis Now model. And I just want to throw it out there to the administration that, I have in a former life, I was a photographer, and, if you have one leg short in the tripod, it's hard to get a good complete photo. So really ramping up that 24/7 operations for the mobile crisis team and the mobile intervention team, very crucial. So I hope we get that going in a timely fashion, and we'll keep that mobile crisis team job classification on the agenda for the next meeting. And again, welcome you folks back to give us more of the financial needs side of things.
Absolutely. We are very close to the finish line. I will say that.
Wonderful.
We really are. So,
Wonderful. Thank you for being here. You bet.
Yeah, thank you.
Okay, we're going to move on now to the next item on the agenda. And this is talking about the Anchorage Safety Center, or sometimes I think it's referred to the Sleep Off Center. And Ms. Rash will be able to speak about this.
Thank you so much. So I did receive a few questions, so I just want to make sure that I address those up front. And so some of the questions were regarding significant changes since 2021 contract with the Anchorage Safety Center. Doing a data analysis over the past couple of years, so looking at the trends, if they were up or down, and then conclusion to the investigation in regards to the incident that happened a while ago. So when looking at the contract from 2021 to 2022, there have been some changes to that contract. Our current contract requires the shift supervisor to be an EMT 2 or higher, whereas the 2021 contract just required an EMT of any level. The current contract requires an operations manager to be on call 24/7 and on site 70% of the time. This position was not required to be on call or on site in the 2021 contract. The 2021 contract required an additional EMT to be on staff during the 8 hours with the highest client numbers, which was typically between 11 p.m. and 7 a.m. This is not currently required. And then the current contract requires a ratio of no more than 15 clients to 1 staff member. And in the 2021 contract, the ratio is no more than 10 clients to 1 staff member. In regards to the van patrol staffing, so the staffing per van, there's no difference currently between 2021 and 2022 contract with that. With regards to the patrol schedule, there's no difference contractually, but we do know that the contractor is having a hard time recruiting staff. So sometimes the vans are not deployed. When the vans are not deployed out in the field, the municipality is not charged for that per our contract. So they are working with, through their HR to try to get their staffing levels. From what I can see, it's only about 1 or 2 vans per day that are not fully operational the entire time. Looking over the past couple of years, looking at the data, and not being obviously familiar with the past here in Anchorage, but looking at that, we can tell that the numbers have significantly dropped over the past 3 years. And what we think and what we, have speaking with Securitas in regards to this is because there's more shelter space. So individuals are not necessarily outside and needing assistance through the Anchorage Safety Center. So we can kind of see those numbers are steadily dropping. In regards to March, so March of every year for the past 3 years has been high. And what we believe that is just the starting of the change in the season and more people going back outside. So that's kind of hopefully answers that question. And then conclusion to the investigation. So the Anchorage Health Department is still working with our legal department. We sent out another request to them to get an update. I do know that they did, Securitas did have their HR individual doing an inspection of the facility and working with their staff. I don't know what has come of that, but we are still looking at, getting a conclusion to this because it is not acceptable what happened. And we don't condone any type of behavior like that. So we're still looking into it and it's still ongoing right now.
Thank you. Just for the public, I'm going to ask you to be a little bit more specific about what you're referencing.
Okay. So I believe it was late December. There was 2 Securitas employees on shift, and there is a video of an individual, of a man in a snowbank. So that individual is seen on film being rolled in a wheelchair out to the end of the property line into a snowbank and being dropped off there. And then the 2 Securitas employees walking away from that individual, thus leaving that individual without any type of care.
Okay, thank you. Questions on this topic, Anchorage Safety Center from members? Any questions? And let me look up see if anybody on the phone is in the queue. Okay, I don't think I have. Oh.
Mr. Chair.
Go ahead, Member Constant.
Thanks. Ms. Rash, I think it would be wise to conduct some kind of a study on the actual causes of the reduction, because I agree it's more shelter, but it's also probably more housing and who knows? And so I think that's probably a good area to investigate a little bit more.
Okay, will do.
Okay, I'm not seeing anyone else in the queue. Again, in the interest of time, I think I'm going to ask if there would be any opposition to changing the order of the day to take up item F before item E under new business. And that would be a review of our ordinance on parental leave policy, because we do have a few members from the community here ready to present, and I want to honor their time. We can take that up before our discussion regarding assembly confirmation of the chief medical officer. Anyone opposed to that? I'm not hearing any opposition. So at this point, I would like to invite those community members who are here to talk about parental leave policy. I think we have, and forgive me if I'm pronouncing any names incorrectly, but Krisha Loescher, Becky Went Pearson, and Stephanie Berglund to present. Please come on up. Okay, welcome. And if you could push the big button really hard so that green light turns on, everybody can hear you, and introduce yourselves.
Hello, I'm Stephanie Berglund, the CEO of Thread.
Hi, I'm Becky Wint Pearson, Senior Vice President of Law and Corporate Advocacy and General Counsel for GCI.
Good morning. I'm Krisha Loescher, the Benefits Manager, recently promoted for the Alaska Native Tribal Health Consortium.
Thank you for being here. And I'll just turn the floor over to you to talk about parental leave policy and your thoughts.
Thank you so much for the opportunity to be here. If you're not familiar with Thread, Thread is the child care resource and referral organization here in Alaska. We have our headquarters here in Anchorage, and our vision is that all families have access to a high quality, affordable childcare system. And we view paid family leave as part of that vision and part of that comprehensive system. While we focus mostly on strengthening childcare at Thread, we work on empowering families, including their choices for parenting, care, and education for their family. Working parents of newborn children face important choices about their continued participation in the workforce, and that's why this is really important. These choices affect their children's development, their career, and their family's financial security and stability. Access to paid parental leave and childcare are two policy pieces that empower working families and ease the difficulty of this decision for families. Thread supports paid parental leave policies as they're important for children, families, and businesses. With paid leave benefits, parents can take time to form close bonds with their child during the earliest developmental stages. It also helps them put them at ease, knowing who will be caring for their child instead of often having to choose between expensive infant care programs and sometimes low quality, all too often informal options. This early bonding time helps foster children's physical, emotional, and cognitive growth. By guaranteeing working parents the time and financial support they need to spend this period at home, we can ensure that all children have access to nurturing environments during their early years. Paid family leave is good for benefiting children, but also the family as a whole. Overall, it supports less stress and offers support and needed time for families to adjust and transition to a new or growing family. Paid parental leave can reduce financial stress for families. It provides the opportunity for families to take a little more time away from work before needing to access childcare, reducing their financial burden of expensive care. As we all struggle to recruit and retain qualified workers, offering family benefits and as many of those benefits as paid family benefits is key. Businesses gain with stronger retention, employee job satisfaction. Businesses, in this case, the municipality of Anchorage, demonstrate support for workforce and promotes continuity in work and job positions. Paid leave shows value to employees and overall our community, which is strengthened through stronger families. Thank you for considering this important policy.
Go ahead.
Thank you. Thank you again for the time and for allowing me to speak here today. So again, I'm Becky Wint Pearson, Senior Vice President and General Counsel at GCI. GCI is one of Alaska's largest private employers with more than 1,800 employees working statewide. I'm here today because we were tremendously pleased at GCI to hear that the municipality is considering adopting paid family leave as part of its benefits package. At GCI, we also recently made the decision to adopt paid parental leave effective January 1st of 2023. All full-time GCI employees will be eligible for four full weeks of paid leave. A few notes about what we did with our benefit. Our policy applies to all employees, male and female, whether they are the primary caregiver or not of a new child. It's triggered by birth adoption or the addition of a new family member via foster care. It's flexible. It can be taken all at once in one chunk, or it can be taken in smaller chunks throughout a 12-month period. And it's also stackable. And I think this is something that we did, which is clever, which is worth consideration by other employers, in that it applies in addition to other benefits we offer, like enhanced short-term disability. So an employee could give birth, take 2 weeks of PTO, receive 4 weeks of support from our enhanced short-term disability policy, and then use the 4 weeks of paid parental leave at the conclusion of that period for a total of 10 weeks of paid leave from their position. And one of the things I really wanted to emphasize today to you all was that when we went through the consideration of whether or not to adopt paid parental leave, we weighed a variety of factors and made the decision for a variety of reasons. I know I think we consider ourselves a good place to work. We've always been a place that Alaskans have enjoyed being employed. We feel like we strive to support our employees both inside, at the workplace and outside of the workplace. So it's consistent with our values to include paid parental leave in our benefits package. But it also makes good business sense. I mean, before we adopted the policy, we surveyed our employees and asked, what is the number one thing you'd like to see added to GCI's benefit package? And 57% of them said paid parental leave. And that's 57% of all employees, not women, not employees of childbearing age. It's all of our employees. We also completed an analysis of where we stood with respect to other players in the industry, where we stood with respect to other employers, major employers in Alaska, and found that we were lagging behind. And as I've heard reiterated multiple times here today, we're all in a place where employee retention and employee recruitment, we're dealing with an environment that is unprecedented in recent memory. And this is a benefit that employees want. It's a benefit that employees need. And it's a benefit that employers in Alaska need to offer in order to be competitive and in order to attract the kinds of employees that we need at GCI, kinds of employees that you all need at the municipality, and the kind of workers we need in Alaska. So with that, thank you again for your time.
Thank you. Go ahead.
May I ask a question,
Sure.
actually?
Member Quinn Davidson.
Okay, thank you, Mr. Chair. So I believe our policy, I would have to check with Bill Falsey, who drafted it based on the PMP that we had implemented in 2021. But I believe you need to take the 4 weeks of paid leave first, and then not break it up. And so I guess I'd be interested in how you made that decision, if you know that level of detail. And yeah, just so we can consider how that might impact ours and whether it's the right choice to move in that direction.
Yeah, so our human resources department has carefully considered employee feedback and what our employee base was seeking, and made the decision to offer that flexibility because employees have appreciated it. And we've received actually targeted feedback on that element of our policy, that employees appreciate the ability to break it up over the year if they want to be able to take more time at various points in their child's first year in the family. And it also allows some flexibility to do some other creative stacking, right? So we have a number of families who have both parents working at GCI. So you could conceivably have, one parent stack their PTO, their short-term disability, their paid parental leave, and then the other parent take 4 weeks after that. So it allowed our employees some flexibility that they've already told us that they appreciate.
Thank you. And I'll just note for the body, since Mr. Volan just asked a question here on the side, our policy that we're putting forward, the proposal at least, is the same in that it is triggered by birth, adoption, or placement of a foster child into a family. It could also be for a guardian if someone's a legal guardian, doesn't have to be a parent. And you can take it in the first 12 months. It doesn't need to be immediately after the birth or other triggering factor, but we might explore whether we could break it up. Just so you all know, I did talk to Bill about it, and he said that HR preferred that PTO that they used. And Randy, you had asked me this question too, but HR preferred that the 4 weeks of paid parental leave was used before PTO, because PTO can be cashable and it's more complicated. And so it's good to get that leave out of the way and then go to PTO. But it seems that if an employee had a preference, I don't know why we would mind. So anyway, I'll explore that. And thank you for that information, Ms. Whitpearson. Oh yeah, Ms. Oh, sorry.
Can I comment on that?
Sure, go ahead.
This is Stephanie Berglund again. I just wanted to comment that Thread also is really proud to offer paid parental leave, and we offer 3 weeks of paid. And we have it written as the municipality has drafted it to exhaust that first before PTO. I'm happy to share that. And I think it's wonderful what GCI is doing. I think full disclosure, we did that out of reducing our own administrative burden and making it easier to track from an HR perspective.
So perhaps that's why the HR has recommended that, but I'll check. Thank you for that, Stephanie.
I have Member Solt with a question as well.
Yes, thank you, Mr. Chair. I do like the idea of using PTO before this, but I have a question regarding whether an employee gets this benefit day one or after the first year, because I can see arguments both ways. If I have to wait a year, I may be trapped in my current role and can't leave. If I don't have to wait, I could see, although hopefully very few employees come, and within a matter of weeks, I'm now out for 4 weeks, then PTO, then out for 4 weeks, and maybe I'll classify as abuse of the system, although hopefully that's very, very low. Just want to get your thoughts on how you went through that, how you considered that.
Thank you, Member Solt. I think Member Quinn Davidson would like to respond.
Yeah, and our guests could as well, but I just wanted, just so it's clear, with our policy, we follow the Family Medical Leave Act, which only allows an employee to take this leave after being in the workplace for 12 months. There is an Alaska Family Leave Act, which allows employees to take the leave earlier. We would like to get to a place where we are offering that. I will share a personal story, which is that my wife became pregnant about, when she gave birth, she had been at her job for 10 months, and they allowed her to take the leave, which was 3 months long, very generous and very necessary, having a newborn. And she loves her job and has no plan to leave that job. And her employer treating her well and trusting her has made her even more committed to staying at her job. So I think we should think about this as a long-term investment in employees rather than people trying to game a system. This is about worker retention and offering good benefits. So anyway, that's the logistics of how our policy works. I hope that long-term we're focused more on the Alaska Family Leave Act that is a little bit more generous and a little bit more accommodating of employees. But anyway.
Any responses to Member Solt's question?
Sure, I'm happy to respond to it on with respect to GCI's policy. We have a number of different things, right? So we also, our paid parental leave operates in concert with Family Medical Leave Act, protected leave, and that we are subject to the requirement of a year of employment. Our 4 weeks of paid leave is all employees are eligible, all full-time employees are eligible as soon as they begin employment. And I think we took the same approach that Member Quinn Davidson was outlining, in that, we looked at we've calculated out, the financial impact on our budget for a year of adopting this policy, and felt like it was a relatively small monetary investment in the ability to really, again, recruit and retain and keep our quality employees and support them through the process of growing their families. So we definitely saw it the same way, as a business, that this was an investment in our workforce, which is a particularly critical need at this juncture for all of us as Alaska employers.
Thanks. I want to do this because I want to go to Ms. Loescher next. And I think, what time is our public safety? We're noticed here till 10:45, and the next one's at 11. So are members okay with extending for 5 minutes? Awesome. Yes. Okay. Ms. Loescher, if I'm saying that correctly, go ahead.
You are saying it correctly. Thank you. So at the Alaska Native Tribal Health Consortium, we implemented our paid parental leave policy October 1st of 2022 as we work on a fiscal year. We made that to coincide with both FMLA, because we have that for our employees, but ANTHC also has its own leave of absence policy. It allows for employees that have recently joined and do not meet the requirements for FMLA to have either 8 or 12 weeks off, depending on the reason for the leave. That is a strict company policy. So our paid parental leave policy works in conjunction with FMLA. We do have a short-term disability policy that is for 6 weeks. And so our paid parental leave policy kicks in after our short-term disability policy to be able to afford our staff some mechanism of pay over the entire 12 weeks of the leave. We do require the use of PTO with our paid parental leave policy, as our paid parental leave only pays 60% of the base wages, but does so for 6 weeks with no cap on income. So every level of employee receives a 60% benefit. We did that, listening to my colleagues, with ease of administration so that it transitions very much the same way from short-term disability. Our paid parental leave policy is for all of our benefit eligible employees, whether they are birth-giving or non-birth-giving parents. We also have a caveat in for parent by surrogacy, and we included, because of the value in our employees, a miscarriage benefit under our Paid Parental Leave Act to support those employees to be able to take the time that they need to recover from a tragic accident or unforeseen circumstance. We implemented this policy through results of employee engagement surveys. We do those on a biannual basis. Overwhelmingly, that was the thing that we were missing. In our, we work in the healthcare field, the 24/7 operation. We require our employees to use it concurrently in order to help staff the needs and fill the positions for all of our clinical practices, our providers. It's an ease in operational management for all of our clinics. And we also conduct a gap analysis every year for our benefits and see where we're missing. And paid parental leave was the absolute thing that we were missing to retain our employees, to have them return to their full-time capacity versus changing to a part-time employee or an intermittent staff. So it helps them with that financial safety net, if you will, for the importance of the 12 weeks and being with their child, whether they're birth giving or non-birth giving.
Thank you. Member Cross in the queue.
Yeah, so I think this is fantastic, and for a multitude of reasons, not just because, you can talk about the financial benefits of providing additional resources to your employees, but, parental participation in your children's lives is critical. And particularly now in light of what we're seeing, what's happening in education and low test scores and mental health issues that are being brought to our attention, anything that we can do to promote parental participation in not just their children's lives, but in education. My kids' schools struggle to find volunteers for field trips and stuff. And, our children need attention. They need to know that they're loved, appreciated, and that they are valued tremendously. And in that search that they have in their lives, if the parent isn't there to fill that void, something else will. And so this is beyond just providing benefits. I'd like to see what we can also do with working. We've talked about it, about remote work options for parents and stuff like that. If they're getting the job done, they're still able and working from home. We've failed on that as far as a municipality as well, as times change, allowing it to happen. But we need to be very realistic that this failure of us to create a system that encourages parental involvement in their education, their lives, is a result of a lot of things that we like to complain about. So thank you.
Thank you. I'm wondering if you could comment a little bit more on the miscarriage benefit. How long of time is that? That's really interesting.
So we allow for 2 weeks of paid parental leave. Again, that is 60% of the base wage with no cap on the wage. It is supplemented by our very generous PTO plan. And we decided that it was the best place to put an option to support any of our employees that have gone through that tragedy.
Yeah, I would definitely be interested in having a little bit more conversation as our ordinance moves forward on that, because I know that can be a really traumatic experience for parents. Okay, at this point, I think what I'd like to do, because we have extended to 10:50, is see if there's any community members here that would like to provide comment, open it up for public testimony. Does anybody have any comments? Ma'am, go ahead and come forward, and then if you don't mind sharing your microphone.
Hi, most of you know me. I'm Reva Katz. I'm the epidemiologist for the Anchorage Health Department and thereby the epidemiologist for this municipality of Anchorage. And I wanted to add my support for family leave for all positions, not just executive positions. As an executive, not that I'm in the parental age group at this point, but I could afford it if I had to. Let's be real. I'm one of those people who could make the advertisement for a single mom who could do everything and, hire a nanny here and daycare there, et cetera. But the people who work in my organization day to day at the other levels cannot. And I think however it's worded, it needs to be very much stressing that it is for all positions and not just for positions of certain levels. While I have the microphone, I have to tell you, as the epidemiologist, I would recommend that in future meetings, those of you who are members of the assembly sit at least on this side of the room. That is the most unsafe corner where you are sitting, Ms. LaFrance, because of the way the room is set up for ventilation. Your epidemiologist can tell you all kinds of things like that. You just need to ask. And on a personal note, in the 15 months I've been in the office, I've never received a single question from anybody on the assembly about COVID, about public health, about a professional evaluation of Dr. Savage's work, about monkeypox, about polio, about how to sit safely in a room, about masks, which ones work and which ones, believe it or not, don't, how a bandana tied bandit style is more effective than a nylon mask that hasn't been pre-washed. I can give you the sources, the data, the information. That's what I do. I'm not quite sure why I'm here. I'm one of the best there's ever been. Ask anybody on 3 continents if you don't use me. So I'll throw that out as well. And I came today in all honesty because I'm the only professional at the health department who could actually give you an evaluation of Dr. Savage's performance in his position. And I'd be glad to do that. I can do that on a daily basis. That's the level I'm at. So if you need to know that, ask me, because the letters you're reviewing have an awful lot of factual errors in them. Without taking any stand pro or con, anything you put out for the public that has public health information that's inaccurate makes me look bad as well as you. So I would urge you to review those and correct them before you put them out for public knowledge. Thank you.
Okay, thanks for your comments. I think Member Quinn Davidson wanted to briefly comment.
Yeah, thank you. Dr. Katz, I assume. Yeah, for being here. I'm sure Member Voland, chair of this committee, would welcome you anytime. It's sort of up to Kim and others who's invited, but happy to have your participation and good to know you're there for questions. So thank you. I wanted to let you know that the reason the policy is drafted the way it is for executives and non-reps is that the assembly by code is only able to provide leave. And it's the same thing with the holidays we just passed, Juneteenth and Indigenous Peoples Day, only able to do that for execs and non-reps. It takes the mayor working with HR and with the legal department to do amendments, which I assure you the unions have told us they are eager and ready to do those amendments quickly so that they can also take part in the holidays and this parental leave benefit should it pass, and hopeful it will. So it really is up to the mayor, and maybe Alexis can whisper to him how important this is. And we're hoping that he'll support it and get this going for all employees at the municipality.
I understand that. I run into the same problem in trying to get interns from UAA who want the epidemiology experience, and Lord knows I could use them, and we have the same difficulties. But maybe you could pass a resolution.
We've got 1 minute, so I hate to cut off the back and forth, but I appreciate you being here, and I think especially salient, given that we're at 34% vacancy in the health department. I'm going to punt our final item under new business just because we're out of time. The assembly confirmation of chief medical officer until our April meeting, and I would entertain a motion to adjourn.
Can I just say thank you to all you for
Thank you
being
very
here.
much.
You were all sitting here through the whole meeting. We know you have really important jobs and big lives, and it's just really valuable to have your perspective here. So thank you so much.
Thank you, and we are adjourned.